Welcome in the seventh webinar dedicating to Dysimmune and Inflammatory Neuropathies. The title of this webinar today is Navigating Life with Dysimmune and Inflammatory Neuropathies. This is mainly a Q&A session on quality of life and management. And my name is Jean-Philippe Plançon. I'm a patient representative and also the chair of the educational board of EURO-NMD. So I'm very pleased and honored to moderate this session. And I would like to introduce you our expert panel. Today, I'm pleased to present you Patrizia Garzena. Patrizia, welcome. You are a patient representative from the Italian Association ONLUS CIDP Italia, and also a board member of EPODIN, which is the European Patient Organization for Dysimmune and Inflammatory Neuropathies. Thank you very much to share your expertise with us today.
Thank you for inviting me. It's a pleasure.
And Dr. Filip Eftimov, welcome. You are a neurologist at University Medical Center Amsterdam. You are expert in neuromuscular diseases and Dysimmune inflammatory neuropathies. And you are also very interested in clinimetrics, biomarkers, and inflammatory neuropathies in clinical trials. So welcome. Thank you very much to share with us your expertise on this domain.
Thank you, Jean-Philippe. Pleasure to be here.
Thank you. So we have collected a lot of questions around Dysimmune inflammatory neuropathies, and I make you a proposal to ask you questions, then you give an answer. Feel free to intervene between you, Philip, as an expert clinician, and you, Patrizia, as a patient. And maybe, Philip, I just would like to start with a more medical question. Say, could you give us to the audience a general definition of Dysimmune inflammatory neuropathies? What are we talking about?
Yeah, so just not to fill up the whole 45 minutes on what it is all about.
Yes.
I think in general, it's a very specific group of neuropathies that are treatable, and that is, I think, the distinguishing character of this. And they can present in different ways. So we have also different names for it in a way. So we have the Guillain-Barré syndrome, obviously, and more chronic variants like CIDP or multifocal motor neuropathy or the peronodal neuropathy. And each have kind of a different presentation, but they do boil down to, at the end, that people can get weakness and sensory disturbances, finally leading to disability. So I think that would be probably the most quick and general explanation on what we are talking about.
Thank you very much. I've just forgotten for the audience to engage you to ask question in a special box on the bottom of your screen. You've got a Q&A space. Please do not hesitate to write questions, and it will be a pleasure for us to answer, of course. Well, thank you very much, Philip. So regarding maybe the journey of the patient, and if we start by the beginning, I mean by the diagnosis, why, if we consider, we understand that there is acute forms and chronic forms, but why is it so crucial to diagnose it as early as possible?
Yeah, so what everyone wants to do at the beginning is to prevent axonal damage. So the axonal damage is if you look at the nerve, you have of the nerve itself, the axon, and then you have the surroundings of the nerve, which is the myelin, that mainly serves to have good speed of the nerve conduction. And generally, we think that if the axonal damage is already there is not much you can do to make it better, and it takes a long time, if it improves at all. While the myelin damage can usually be reversible, so people can also improve rather fast if you intervene at that point. And although we call them often demyelinating neuropathies, meaning that it starts with the problem of the myelin, what you see is in some patients earlier than others that you get this axonal damage. And this is why also we are trying to treat them as fast as possible preferably during that phase that primarily the myelin is being attacked and you still do not have axonal damage. So there is kind of a sense of urgency that you want to treat as fast as possible. And whether this urgency is in matters of days or weeks or months, I wouldn't say months, I think, days or weeks, that kind of depends on how progressive the disease is. So we know, of course, some forms like the Guillain-Barré syndrome can be really progressive. Some even within 1 or 2 days can even end up on the ICU with respiratory weakness. And it's very clear that it's in these patients, and actually I would say all GBS patients, you want to have the diagnosis as fast as possible and actually treat the same day or start treating. And of course, for the more chronic forms, sometimes it's also more difficult to get to the diagnosis you do because you can have more other diagnoses that you have to rule out. But you can certainly need sometimes a few weeks to get the diagnosis. But even then, I would say try to make the diagnosis as fast as possible.
Thank you very much. Patrizia, I come to you in a minute. We are just finishing the medical part of the introduction, but a complicated question also for you, Philip, please. From the patient perspective and also from the clinician perspective, I think, why diagnosis can in some cases be so long? When we are talking about diagnosis wondering, sometimes for patients it can be very long journey, but probably for the clinician too sometimes.
So I think this is mainly the case for the chronic forms. I think the acute form are usually most physicians can recognize Guillain-Barré syndrome because it's often a kind of a classic presentation. So in most people, chronic forms can be a bit different. So first of all, it can resemble many other things from the beginning. So it can be therefore difficult, and especially if you don't have a lot of experience as a physician with this specific diseases, which is rare, however you take it. But I think even more than that, more often the delay lies in that in the beginning that there are only very mild symptoms and sometimes not even recognized by the patients, or they just first go to the general practitioner and they just only have that feeling in their feet, and indeed it can be possibly caused by polyneuropathy. But if you're 60 or 70 and you have only some deaf feeling in your feet, I mean, then it can be polyneuropathy, obviously, but 99 out of 100, it won't be CIDP. So it probably will be just a very, common cause of polyneuropathy like diabetes. And then there is less urgency to set a diagnosis. It's different, obviously, when people present with disability very soon. That should be a red flag to do additional investigation as fast as possible, I would say. And this is usually not the case. So the more in a kind of the less progressive the neuropathy is, probably the bigger the delay, because at the beginning, people are just waiting, both from the patient side, there is sometimes less urgency to take steps, but also from the physician part. And always, of course, the last doctor is always right. So it's in the beginning can be also very difficult. Even I can imagine that even a classic CIDP patient, if I would see it as the first doctor in the first couple of days, I might also think, well, it's not probably CIDP, maybe something else. So it also the further you are in the disease course, also the easier it is also for physicians to recognize it. And then, of course, you have the method that you do need to do the proper investigation afterwards. So if once you do have a suspicion that it might be CIDP, then I would say do the proper nerve conduction study with several nerves and not only 2 or 3 nerves, and then you only get kind of a partly information of how the nerves are, and maybe you miss the diagnosis because you just didn't test enough nerves. So there are, I think, more sides to the story.
Thank you. So it can be an advice for general practitioner and also for general neurologist, just for the GPs to refer as soon as possible toward expertise, and for general neurologists to not hesitate to refer to an expert center.
Completely agree. If there is suspicion of something else than the really general neuropathy, I mean, patients with diabetes who are 70 or 80 with tingling in their feet will often, well, sometimes not even referred to a neurologist by a general practitioner. Then it's like 1 + 1, it will be 2. But again, if you have disabling symptoms very soon in the disease course, I think that is very important reason to refer as fast as possible.
Thank you very much. Patrizia, thank you again to be here. So what disease do you live with?
I have been living with CIDP for 8 years now.
So CIDP, this is the chronic form
Yes, that's the
that we talked
CIDP.
just.
I was, as I said, I was diagnosed 8 years ago.
And we were just talking about diagnosis. Can you tell us more about your own experience of diagnosis?
Yes, maybe my story was a little bit different because I had that mild symptoms Filip mentioned, but then the disease struck all of a sudden, and one night I woke up with excruciating pain in my legs and my arms, and from that moment my life was changed forever. And I must say that I was living not in Italy, I was living in Sweden when I got ill. And I went on for months. No one realized what was wrong with me. And no one was aware about how serious the situation was. And so I ended up losing most of my strength in the legs and in the arms, and I have a lot of pain. I had a lot of pain, unbearable tingling and shocks and cramps and all the array of sensitive symptoms. I had simply no idea what was going on with my body. I was terrified. I was even sent to a psychiatry unit once because they thought I was a kind of a weirdo. They thought I was making up, and they thought that my symptoms had to do with kind of depression or whatever in my psychological sphere. And when I finally managed to return back to Italy, I went to a very small hospital in my own town. I live in a very small city. And there, finally, just in 10 minutes, the neurologist who was on duty in the emergency unit understood what it could be. He had simply the right idea, the right insight. And 2 days later, I had the diagnosis, and then 4 days later, I was finally in treatment. When it comes to procedure, I got lumbar puncture and electromyography in the diagnosis phase. And I was treated first with plasma exchange, and then I went on to immunoglobulin, but later on in my patient story. So that's it. And it was an incredibly difficult time because when I was diagnosed, it was a relief in a way, because I finally know what was happening, what was wrong. But in the meantime, it was opening a lot of questions, because I got to know that it was a rare disease, and I didn't have any idea about what would be living with a rare disease. So a lot of questions, a lot of uncertainty, a lot of scary thoughts, and so on.
Thank you, thank you, thank you. So from the onset of your symptoms to the diagnosis, how long would you say that, what was the duration more or less?
In my case, more or less 3 months.
3 months.
It's
Okay.
not that much. I know that people sometimes wonder far much more. So I was lucky in a way.
Yeah, in a way.
Yeah.
Okay, thank you. Maybe Philip, just a question, because we are talking about diagnosis regarding the psychological aspects, because this is when we discuss with patients, when we see patients in our patient organization, these criteria, this topic always come to us. So how do you manage it in as a clinician?
Yeah.
Sorry for the difficult question again.
Well, of course, this is not specific for CIDP. It's for every disease where you just at the beginning, you don't know what it is, and you need additional tests. And sometimes, and I mean, I work in a tertiary hospital, so there are also enough cases that you still don't know what they have, even though you have done more or less everything that you can think of. I think it's very important from the beginning to be very transparent on the options that you consider, and to give them a feeling that you're really searching and looking for the diagnosis. And sometimes, like in this case, you could even say that it's very likely that you will find something that is treatable. But sometimes, for example, in an MMN group, it's a good example. The biggest alternative of MNM is that they have motor neuron disease and amyotrophic lateral sclerosis. So, and unfortunately, usually it is ALS and not multifocal motor neuropathy, because it's just much more common. So, but you have to be, I think, in a way, very transparent also, whether you think you can find something, and be open. But yeah, it's always a balance of being open and not scaring people too much from the beginning, what it might be. There is also, I think, some differences in cultures and how people approach this. I know Dutch are very blunt and direct, but I myself come from Yugoslavia, or ex-Yugoslavia, so we tend there, for at least not to tell the truth, kind of a paternalistic way of approaching patients. And I don't know how it is in France, man, you might comment on that, but there are differences. And I think every doctor makes their own choices also on how they kind of do this part of the, well, how they break the news and how they follow up the patients with that. But it's certainly a very anxious period. And even when you have set the diagnosis, the CIDP, then of course you still don't know how people will respond to the treatment. And then even then you have, of course, also this discrepancy sometimes, that you as a physician can be perfectly happy about how people have responded, while the patients are not that happy. And sometimes even vice versa, that you feel like then there was very limited response, but patients feel completely happy at how they are doing. So and of course you need to kind of get a feeling also, and normally you get to know your patients and then and go along. But sometimes you have this discrepancy also, and it remains all the time. And the question is, of course, where this discrepancy lies. I think GBS is a very good example. When I started my residency, the general reading about GBS was that is a self-limiting disease and that most patients are doing really fine at 1 year or 2 years. And yeah, that might be the case if you look at loss of strength or all the impairment measurements what you do. But if you look at what they are doing in daily life, often this is not similar to what they did before their GBS. So it does have a huge impact in many people. And every year we have the patient group meetings, obviously with GBS and then CIDP. And we always talk about the fatigue, the pain that have kind of remained and still are very important things leading, I mean, in every daily life activity. So, and this is for us, for neurologists, also frustrating because there is not much that we can do often about this because there are usually the residual symptoms, often this axonal damage that I was talking about, that it's just not amendable to treatment anymore. No, not at least not to the inflammatory treatment that we are giving, not the medication like IVIG, plasma exchange, and corticosteroids and etc. So it does need another way of approaching this. But also be very clear on this sometimes that yes, you might also have residual symptoms, but it doesn't mean that you cannot also do your stuff again in daily life.
Thank you. Precisely regarding the holistic view, we have started to talk about and the management. Patrizia, regarding the multidimensional impact of the disease, which aspect do you think deserve to be highlighted around the CIDP, or maybe more around the chronic form?
Well, as we are already talking a little bit about the psychological aspect. As I said, I have been a patient for 8 years now. No one has never asked me simply how you feel. How is it to live with this disease? Of course, I have got a lot of good treatments. I'm happy with what I've got, but the psychological side of the disease has been completely neglected. And this is one point. But even rehabilitation is another crucial aspect that sometimes is not taken into account along the path patient go, because rehabilitation is very important in the beginning. But I think that rehabilitation is important all the way long in different phases that a patient go through. And at least here in Italy, you cannot have rehabilitation when you need it. You have access to rehab even in very specific conditions and circumstances, and so many patients just have to pay to have rehabs or some kind of physical activity. So this is another aspect that I think it's important to highlight. Yes, I think this mostly these two, psychological impact and rehabilitation.
Well, thank you, Patrizia. Philip, regarding rehabilitation, for sure, we are talking about neuromuscular disorder, debilitating diseases. How do you implement in your clinical practice rehabilitation with patient? Of course, I'm sure it's depending of your patient, but we can understand that it can be very challenging. Patrizia made a testimony around that.
Yeah, and I think it's also a difficult question in a way when to start it, because in what you start. So I think I completely agree with Patrizia that it should be offered to most patients. I mean, some just are really good and don't need even treatment, you know, so they might have symptoms, but that they're not there, have no disability at that moment, so rehabilitation won't be helping. But it's sometimes a bit strange that a patient who has GBS and is admitted here gets really, well, the whole shebang in terms of rehabilitation. Everyone is involved. Well, CIDP patient that can just go home, let's say, and not necessarily go to a rehabilitation center as after the hospital, needs to kind of fight for their rehabilitation place. And one of the problems might also arise from the uncertainty how fast people can improve after starting treatment. So if you start IVIG and maybe steroids to a lesser extent, sometimes you see a extremely fast improvement. So if someone is in a wheelchair but can make transfers and can go home in a way, sometimes I also feel like, okay, let's await what the first infusion does in 3 or 4 weeks, and then we can decide how much is necessary in terms of the polyclinical rehabilitation, because it's also difficult for people to go in and out all the time and get the physical help, and it changes every week. So, but I tend to get them into rehabilitation rather faster than later. But I do recognize that this first couple of months, perhaps, a lot is changing, but also for the patient, a lot is changing also psychologically, and getting out of the wheelchair might be very important. But then the next step arises that you want something more, obviously, from patient perspective, and then there might and at a certain point this moment arises indeed that you feel like, okay, now, because most patients with CIDP and MMN, they will see their improvement rather fast, and then it goes only like this, and that can take for months and years, and not infrequently then actually the problems start. Like, okay, now sometimes in the beginning they can be very optimistic. Okay, now we are going up, and then this going up kind of stops, or it's less obvious, and then this realization comes that, okay, but it seems that I'm not going to be there where I was before. So yeah, so this is a difficult process, and I think also it's especially here with the rehabilitation, you also get the medical psychology if necessary, so the rehabilitation doctor can really help in this, and maybe address this need if necessary. Not every patient needs medical psychology in a way, because just talking to the physiotherapists and ergotherapists might be enough, because this is what they hear. But some can also have problems with just accepting the fact that they have a disease. So it kind of depends on it should be suited to the patient, I would say.
Thank you. Patrizia, when we prepared this webinar, we talked about the unpredictability of nature of the disease, because as patient, the fluctuation of the disease and symptoms is very challenging. Can you say a few words around that?
Yes, I think that unpredictability is the key word in all the story, at least in my story with CIDP, because you can no longer rely on your body simply. And one day it's okay, one day it's not. And your life is always ups and downs. And as Filip said before, we're living with fatigue constantly, more or less. And then we get treatment, so we go up, and everything is fine, and we feel fine, and then we go down again because the treatment stops to be effective. And so yes, it's always living in cycles, lots of ups and downs between the treatments especially, and this experience of fatigue it means even that you have a less confidence in yourself sometimes because you don't feel fit. And everything, it's more difficult, even very simple, basic daily tasks.
Well, thank you for that.
And everything changed so rapidly. You could never rely on what you're feeling today, because tomorrow it could be totally different.
Philippe, could we say that the unpredictable nature of a CIDP, for example, is specific, more or less specific of this type of pathologies, the up and down way that we as patients are living with? Or
Well, I think there are the two different things here. First of all, there are also a lot of CIDP patients who are stable. So that do not have this kind of fluctuation, certainly not on a daily level. But at the same time, you do have this daily level fluctuations that I think more often is not even inflammation, because it wouldn't be logical that inflammation one day and the other day better. So that is probably just also kind of the residual symptoms that are just above or under this level that you can do at that certain moment. But we do see more often fluctuations, like for example, if they have a fever for a viral infection, that they get worse for a couple of weeks, and then it takes them weeks just to kind of get back to their previous condition they had before. So, and sometimes also we have, of course, the people who are on IVIG who are not completely stable on their IVIG and have this wear-off effects a couple of days before their next gift. And then, yes, we are trying to kind of avoid those fluctuations, but it's not always possible. But indeed, the more general question beneath this is you have an autoimmune disease, and it can flare up, and you can, and that is a certain uncertainty that people often live with. And this is also what I hear also from colleagues, also from the MS world, from the rheumatic diseases. So this is always something that is kind of above your head, that it might flare up. At the same time, of course, I think CIDP, I mean, it's chronic, but it's not always chronic. So people can get off treatment, and people always ask, so how long is this period that I need to be scared that I would get my flare once I stop treatment? We know that the most patients, if they flare up, will be flaring up within a couple of months. So it's also kind of reassuring that if you don't have a flare for a year, I cannot say, unfortunately, that it won't happen afterwards, but the chances are really getting smaller then. So most people have just active disease, and they do usually pretty good on treatment. Some do have these relapses going up and down, and that can be very frustrating, obviously, because it's, as you say, Patrizia, it can be completely unexpected. But it's and honestly, every patient has kind of different view on their own disease. I mean, some can handle this better than others. And some have, and maybe some have difficulties with the first year, but they get used to it. And some don't get used to it, never get used to it. So it's I don't know. It's also how the mind works of people, and their character is, I think, also part of it. And this is certainly not that physicians will change, but also patients cannot change. They can get sometimes some help with this, how they. And this is probably the part that medical psychologists might help in this, how you view things, and you can get some help in that. But my general opinion is that usually your character won't be changing. It's like the glass is half empty or half full, and you always look at it that way.
Thank you. So beyond the character, there is social and work burden aspect of the disease. And Patrizia, you how did you have to adapt your life around the reality of the disease regarding your work, for example?
Well, of course, you have to rethink your working life. In my case, not that dramatically, but I know people that had changed completely their profession because they couldn't do the profession they had after the disease. But even if in my story, I have of course made changes along the path because I cannot walk for a long time right now. I have difficulties, and as I said, fatigue. It's a symptom. It's very difficult to bear and to manage. And and then treatments take a lot of time out of your life, out of your working life. I spend more or less, I wrote down 2 months per year in the hospital, more or less, if I count treatments and reassessments and, well, tests and whatever. But it's an average of 2 months per year in the hospital. And of course, it's 2 months that I have to get from other parts of my life, work, family, and everything. And well, you have to adapt to this. It's not easy. Sometimes it's easier for you that you're bearing the disease, but it's more difficult for people around you, families, friends, colleagues. I know patients that they have simply hidden their disease for colleagues, for instance, or for bosses, because they didn't want to get this kind of stigma on themselves. And because it's always difficult to explain that you have a rare disease, that you have a neuromuscular disease, and people don't know anything about. And there are still a lot of stereotypes, I think, about rare diseases and neuromuscular diseases and so on. So it's a difficult part too.
For sure. Philippe, compared to other pathologies, we've got the impression, and it's not only the impression. And when I'm talking about other pathologies, I'm mainly thinking about cancer. We have the impression that people living with Dysimmune inflammatory neuropathies very rarely benefit from holistic and integrative support, like just we said before, psychological support, physical activity rehabilitation, or social support. Mainly we think that we see the organ and not the rest of the patient, if I can say so. What are according to you, the obstacles or maybe the opportunities for improvement if we consider these aspects of the care?
Yeah, well, I recognize also what Patrizia says. It's a rare disease, but on itself, if you say CIDP might be rare, MMN might be rare, GBS might be rare, but if you say it's a neuromuscular disease, then it's not rare. I mean, and what exact type it is, you could also say it's completely irrelevant, because what you are looking at, or what your boss is looking at, or your friends are looking at, is just someone who cannot walk as they used to, or they don't have the condition to sit through a whole night or talk through a whole night. So they see basically the disabling part, and for them it's not even that important whether it's inflammatory or not or whatever. So they just see the sequelae of the treatment. Might be a bit different with the fluctuations sometimes again, but in cancer, what they did, they call everything cancer. And every physician knows you have so many types of cancer, but that doesn't matter. And we are sticking to this rare diseases naming in a way rather than lumping them. And in terms of society, it might be better not to make a rare disease of it, just to make it a neuromuscular disease, and get the lobbies and opinion to, okay, we have to act accordingly. And yes, of course, it's necessary to have the subtypes, because otherwise you cannot treat it adequately. But this is, I think, what cancer has done very good in terms of awareness and making it a huge problem for society. It is a huge problem for society, but they created this awareness, and therefore everyone with cancer, regardless of the cancer, gets this kind of a VIP treatment in a way, you might say, if you compare it to neuromuscular diseases.
For sure.
And I think that it's also the whole field, all the stakeholders have worked on this. So it was not also overnight for the oncology field, and they made it happen, let's say. And this is something that we should do also for neuromuscular diseases. So it's way bigger than only inflammatory neuropathies.
No, very interesting, very interesting. Maybe because time is running, we could say a few words about treatment access. We started to talk about that, of course, but maybe Philip, because you've got the floor, the usual treatments may substantially, we said, improve the quality of life of patients. But what can you say? What can we say about this current treatment? What can we say about that limitation and efficacy? I know it's a large question, but maybe I'm talking about the main treatment, like immunoglobulin, corticosteroid, and so on.
Yeah, I will try to keep it short, because I see also some questions coming now. Maybe we have some few minutes for these questions.
Yes.
In general, I think most of the treatments in CIDP and MMN are doing pretty good, to be honest. And yet there are some patients that just, it's not enough. And we are, of course, looking for new treatments. There are a lot of new treatments on the way, complement inhibitors, FcRn inhibitors, etc. But we need to know yet what their place will be in current treatment, because they have not been compared to the standard treatment so far. There have been only research in selected populations. So I am enthusiastic about the future, but we are not there yet. I think we need more trials to see how we can improve the treatment with these new modalities.
Thank you very much. Patrizia, you said a few words about the way you live with treatment. You talk about the burden of the treatment, the accessibility and shortages. Would you like to add something related to the way it works for you, or around the burden, around the efficacy, around the way your perception around that?
Yes, I have been getting IVG since 7 years now, and the treatment works fine for me. And the real problem with IG is shortages. That's the real trouble, and especially during the pandemic, there were lots of trouble to get your treatment ready, and a lot of delays, and people went back to steroids and so, because the immunoglobulins were not available. And we still have troubles right now, here and then, in Italy at least. And of course, these add more uncertainty to something that is already very uncertain. So you live with an unpredictable disease, and even the treatment is unpredictable. Not because it's not working, because it works pretty fine, but because it's not there when you need it. And so it's it's a tricky situation, and as you said, Jean-Philippe, it's a burden for patients. One more. burden for patients.
Thank you for that. So we've got 15 minutes, and maybe if you agree, we're going to take the question that we received. We received a question for you, Philip, around vaccination. A question said, I think it's from a clinician. Yes, of course, it's from a clinician. We said, I have several patients with CIDP, MMN, who travel a lot, and vaccination may represent an important limit. I know that the general approach is that vaccines are safe, but does it apply to all these non-obligatory vaccination related just to come travel issues? I know, Philip, that you have worked on the vaccination topic, and what are the current recommendations around that for people living with CIDP or MMN mainly?
Yeah, so I read the question before. Indeed, and the clinician also states that he's also aware that live vaccines are contraindicated in people who are using immunosuppressive. So that is also good to point out. But in general, I think by a vast majority we won't be having any problems with vaccination. So we had the luxury with the COVID vaccines that we were able to study also whether diseases also can flare after vaccination. I must say I have 1 or 2 patients who always, when they get a vaccination, regardless of what they get a kind of a flare of their CIDP. Those are usually also the patients that also get flares if they have this viral infection, for example, just pumping up their immunity for whatever reason. They get an increase of CIDP symptoms. But if you look at the big studies in autoimmune diseases in general, it actually seemed that the vaccination on itself was not risk factor to get more complaints after the vaccination. So basically the people who were getting these fluctuations after vaccination had also very active disease before the vaccination. So you can imagine if you have regular fluctuations and then you get a vaccination somewhere in between these regular fluctuations, often people will say, well, this came from the vaccinations. But if you look at large studies, actually, this is usually not the case. So it was a kind of a reassuring. So in general, I would say there is no reason to not to get a specific vaccination. Also, if you go to Thailand or whatever, with the exception that if you had very clear symptoms after a specific vaccination, or even got GBS after a specific vaccination, please don't get the same vaccination. I mean, but that is kind of a common sense. But even having said that, we also know from the COVID that people got myelitis and other autoimmune diseases, and afterwards it was after the first or second vaccination, and then it was, you would even imagine that if they would get a new COVID infection afterwards, that they might also be very prone to getting the same symptoms again, because from pathomechanistically, you would gather that the same reaction that you get the first time might be repeated again, because you still have the B cells and T cells that may get activated, your white blood cells. But actually that we didn't see that often. So, or actually never, this repeated severe symptoms. So in general, I would say it's safe.
Thank you very much. Another question around the relationship between multiple sclerosis and CIDP. Is there any relationship between those two pathologies? There's some commonalities, differentiation of symptoms, and is there any scientific proof that having multiple autoimmune diseases estimates a mild progress?
Yeah, so in general,
very easy question.
Yeah, very easy. No, I think I would say in general they're unrelated. There are very rare forms with specific antibodies that you can get clinical pictures that resemble MS, and they have CIDP. So then you're more into this paranodal like antibodies, or the combined central with peripheral demyelination. But in general, I would say they're unrelated, other than we know that if you have one autoimmune disease, that you have a slightly higher chance to get another one. So in that way, that might be related, that you are more prone to autoimmune diseases, but I wouldn't directly say that one is related to another. And the second question, whether if you have two, that you will have a different disease course from either the MS or the CIDP, I would say not necessarily. I think you have the same chance as any other to have either a relatively mild disease course, but also there is also possibility to have a very severe course. Having said that, those that are really linked to each other with one specific antibody usually have a very serious disease course.
Thank you very much. A question from the chat and from Massimo Mara from Italy, which is Massimo is the president of the Italian patient organization. And Massimo says, in the Italian experience, over the years, the average time to reach the diagnosis has greatly decreased. And the most recent patients who have contacted us often mention only a few months. According to you, Philip, is there any gender-related differences in the way men and women describe symptoms or pain? And did you notice any gender differences regarding what the illness means within the family, at work, and in social life? Well, is there some differences between men and women?
I think there are
Easy
many
question too.
I think there are many differences between men and women. But in terms of taking the history and listening to their complaints and how disability affects their lives, I cannot say that I've seen systematic differences between how they present themselves. I would rather say that there are more differences in culture rather than gender in how they present themselves, both with pain. More southern people, I would say, even myself coming from the south, they might present a bit more with the pain than with the disability. But in general, I don't think it's a big difference there. And again, I think it's more the differences are more between patients themselves and characters again than rather than really sex driven.
No. Patrizia, is it sex driven?
Sorry?
What do you think? Do you think there's some differences between men and,
Well,
and
it's a
women?
very interesting topic, I must say. I don't know. I don't know. It was a very interesting to listen to Philip's answer because well, it's as I said, it's a very interesting topic.
Yeah.
Maybe we have to explore it a little bit more farther in some way, I think.
Oh.
Well, we have big databases. I mean, Eduardo, in Italy, and we have also a big database. So we could look whether differences in terms of muscle strength and whether they are complaining about versus what disability is. Disability at the end is how you feel that you can do something, and that there might be some differences.
And maybe in the diagnosis, wondering, we have seen in heart failure diseases that there can be huge difference between women and men in terms of time to have a diagnosis. I don't know if there's something to explore or not. Well, we've got 5 minutes. Maybe I've got a question for you, Philip, and if you agree, we have the impression that the outlines of the autoimmune neuropathies are being redrawn. In recent years, we have witnessed the emergence of new entities, and you were in for sure. And I'm thinking about nodopathies and paranodopathies. And at the same time, the identification of new antibodies can sometimes be linked to certain phenotype of Dysimmune inflammatory neuropathies. What is your opinion on that? Are we writing a new page on the DIN diseases area? I mean,
Yeah, we are basically, because we know that it's very important to recognize these specific, extremely rare cases, to be honest, because I mean, I see maybe one paranodopathy per year and against maybe 50, 60 patients. So with CIDP, but not even new ones, but 20, 30, then one maybe has a paranodopathy. So it's really rare. So we are splitting, and so there is always the discussion within medicine whether you are splitting or lumping. So, and we were not able to split them before, and we just called everything in every paper we start with it's CIDP or it's heterogeneous disease, etc. But now we are trying to split them into separate categories because we do feel that they need to be treated differently. So that's really important. So we are going a bit to this more precision-based medicine, let's say, than only do the one-size-fits-all. Having said that, there is a long way to go. So we only kind of identified a very small subgroup within what we called CIDP before, and this might also apply to GBS in a way that some might react to other treatments and not only to IVIG or maybe something else too. So yes, we are doing that, and of course we need more research to be able to continue on this path. But the main problem is we don't know what is driving the disease directly. So CIDP is one of these diseases that we just don't have the antibody. So myasthenia gravis, for example, it's in a way much easier because you know what the directly pathomechanistic mechanism is. And if you introduce new treatments or potential treatments into trials, then if you know what it does to the antibody, then you have more reasonable arguments to say, well, this should work in myasthenia. And this is one of the problems that we have with CIDP. And there might be also different diseases in this single definition, what we call CIDP. So yes, I do agree we have to go on this way of trying to dissect it more, but mainly into the pathomechanisms at the end.
Mm. And is it realistic to think that if we find the right biomarkers in front of the right phenotypes, we could, for the future, saying, okay, this type of patient, this classification of patient will change?
Yes, that's the holy grail, obviously, to find that, and for each patient separately, individual. I think it's going to be very difficult, but I don't know what the future will bring. But I do know that in the last 6-7 years of research on biomarkers until now, my conclusion is that there won't be a one biomarker that will kind of help every patient, but you might kind of, again, dissect, for example, people where you think the complement is very much activated. So if that's the case, they might be maybe suited for complement inhibition as a new treatment. So I think we should go into that direction in a way, but finding the single biomarker that will help for everyone, I don't know. I have not seen them yet, and even the preliminary results from other studies, I'm not sure that we're gonna find them at this point.
Thank you very much. We have got 2 minutes. Patrizia, just would like to let you the last word. What could be your expectations for the future for people living with inflammatory neuropathies? If you had the possibility to have a wish, 2 wishes, 3 wishes, what could be the best way to be cared, to be treated?
Well, of course, it's the clinical trials that are going on right now are very promising. So I really do hope that some new treatment will come up sooner. And of course, this is one hope I have. And in the meanwhile, while we are waiting for the new treatment, I really do hope that every patient will get access to the treatment they have the right to. This is, you know, how much equity is dear to my heart, because I think that everybody must be the treatments they need when they need it. And it has to be the same all over Europe, in all countries, without any differences and inequalities. This is, well, my biggest wish for the inpatient right now.
Wow. Thank you for this realistic wish. Philip, I would like to thank you really for your commitment during this series of webinar. It was a pleasure to have this discussion. Thank you for the patient community. Thank you for the clinician community to share your expertise. And thank you, Patrizia, today for sharing your story and also your expertise with the life with the disease. Thank you very much, and bye-bye.
Thank you.
You're welcome.
Bye-bye.
Thank you, Jean-Philippe. Bye-bye.
Bye-bye.
Bye.
We have a heart flying in and out.
Ah,
Yeah.
yes. Thank you for that.
Did you put it there?
I don't know. Vietnam as well.
Still open for the panelists.
Thank
Right,
you,
Paul,
everyone.
blessing.
It was a really interesting webinar. Thank you so much. So
Thank you, Dan.
I'm going to end the webinar now, but we can follow up by email if you'd like to share comments. Thank you very much.
Thank you very much.
Bye-bye.
Goodbye.
See you soon. Bye-bye.
Thank you so
Bye-bye.
much. Take care.